welcome to Medicine in Our Backyard. So happy to have you here. You're not home watching baseball. Anyway, this series is presented by the Newport Beach Public Library Foundation in partnership with UCI Health. My name is Adrienne Windsor, and I am a board member emeritus, and I have the pleasure of introducing our speaker tonight. So we want to thank our generous sponsors, Mike and Polly Smith. A member of their family is here tonight. Jan, will you raise your hand? Their daughter is here with us. They have been our benefactors ever since this program started, so they're very important to us. I'd also like to thank UCI Health for their sponsorship and for bringing these wonderful doctors to us every month. Now, I can't ignore the fact that this program is put together by two absolutely fantastic women. Kunga, our program director, and Jane Merritt of UCI Health. Let's give them a hand. So a little bit about the foundation. Jerry told you about the fundraising we're doing for the new lecture hall, Civic Auditorium. The chairs you're sitting on were donated by the Library Foundation. We have all of these wonderful free programs, and then we have the Witty Lecture Series and the Library Live Lecture Series. We are probably the only library foundation that does programming. So we're quite extraordinary for this very extraordinary library. How many of you are members of the foundation? Oh, that's great. If you aren't, please join. Please become one of us. Now, a few reminders. The program will conclude with Q&A, so please save your questions to the end. If you haven't silenced your phones, please do it now. And then let me ask, before I introduce our speaker, how many of you have something artificial in your body? All right, I wanted him to know. So our speaker is Dr. Ryan DiGiovanni. He is a fellowship-trained UCI Health orthopedic surgeon. He specializes in hip and knee arthroplasty. His clinical interests include the management and surgical treatment of knee and hip arthritis, including primary and revision arthroplasty procedures. Dr. Giovanni earned his medical degree at the University of Arizona College of Medicine, Tucson, where he also completed a residency in orthopedic surgery. Next, he completed a fellowship in joint replacement at the Keck School of Medicine at USC. So he's here to guide us through our aches and pains. Please join me in welcoming Dr. DiGiovanni.
Thank you so much for that nice introduction, and thank you guys all for being here, even during the baseball game. And the Dodgers are up 3-0. So I'm going to go through this. This talk is geared towards knee arthritis and the treatment. I'm going to save plenty of time for questions, and you can certainly ask about hip arthritis and its treatments as well. So just a couple of disclosures I have, but starting off, the knee is a very complex joint. There's a lot of ligaments and tendons that surround the joint and help give it its stability. They provide strength, stability, and flexibility to the knee. This is a view on the left here is the back of the knee, and you can just see how many tendons and different orientations are in the knee. And at different points of our knee range of motion, some of those are more tense, some of them are looser, and they help give our knee the stability and control as we go through motion. This image here on the right is the inside part of the knee, or we call it the medial aspect of the knee. And same thing here, that these tendons and muscles all work in concert in order to allow our knee to have the stability throughout range of motion. We kind of break the knee down into three compartments. So there's the medial compartment, which is the inside. The lateral compartment is the outside. And then the patellofemoral compartment is underneath the kneecap and the top of the knee. So we call that the trochlea. We have a lot of motion in the knee. So there's 6 degrees of freedom. So this means that there's flexion and extension. There's varus and valgus. There's internal and external rotation, and there's anterior, posterior, and as well as superior and inferior translation. So the knee can move in a lot of different ways. And those muscles and tendons control a lot of that movement as well. There's really important structures inside the knee. So the one that we're going to talk about today is the articular cartilage, and that's the top there. So that's the femur that we're looking at. And you see it in its healthy form. It's just this pristine, pearly white structure. The probe that's in there is touching the meniscus. And so the meniscus is a cartilage structure that's kind of like a shock absorber. The cartilage, when you have 2 cartilage structures against each other, the coefficient of friction that it produces is less than 2 ice cubes together. And so that cartilage is a really amazing structure that provides, really gliding of the knee and of the joints that the cartilage is on. One of the issues with it is that it's avascular, which means that there's not a good blood supply to it. And so if these structures get damaged, there's not a good way for them to heal themselves. And so that's one of the reasons why we develop arthritis and it progresses, is because without that blood supply, it doesn't heal when it's damaged. And so this is a cartoon illustration of kind of the meniscus as well. So there's a meniscus on the inside and the outside. We call those the medial and the lateral meniscus. There's also the lateral collateral ligament, which is one of the main ligaments on the outside part of the knee. The medial collateral ligaments on the inside part. Inside the knee, we have what we call collateral ligaments, cruciate ligaments. And so the anterior cruciate ligament, or the ACL, a lot of times you hear this in like football players or professional athletes that tear their ACL, and the posterior cruciate ligament. But these ligaments are important to help the knee with range of motion, because as our knee bends, the femur rolls back on the tibia, and this allows for deeper range of motion, because if it were to stay just in the front of the knee, we'd have like 90 to 100 degrees of flexion, which most of us have about 130 to 140 degrees of flexion, and a lot of that is driven by the posterior cruciate ligament and the anterior cruciate ligament working together to help that femur roll back on the tibia, so it can bend deeper and without running into the tibia. So with all of these structures working together, they can be injured, and there's a lot of reasons why we can develop knee pain. So any one of those ligaments or tendons can get injured. The cartilage can get injured, the meniscus. And so what we do as orthopedic surgeons is we first identify the injury, and then we manage the conditions that affect the joints. And so as a joint replacement specialist, we specifically train in the hip and the knee. But we're looking to improve pain and ultimately improve function of our patients using a combination of medications, therapy, bracing, and potentially surgical management if everything else fails. And so really what I'm looking at when a patient comes and sees me, and it's great to see a lot of my patients here in the audience as well, is what are your activities and what is it that's limiting you, and how do we get you back to those activities? And so that's really my goal, is trying to understand what's important, what's lacking, and what is potentially the limitation. And so we do that through a few ways. And so one is a really thorough history of sitting down, listening, and trying to figure out, what you're telling me and how that adds up with the anatomical structures that may be affected. And then a comprehensive physical examination to try to identify this. And, one of the common things, knee pain can actually be coming from hip arthritis. So it's really important that we examine the whole patient and, watch you walk and see how everything's working together. And what functional impact is this having on your life, and what activities or walking is being disrupted. And so arthritis is kind of a catch-all term for when the cartilage is lost between the bones. There's different reasons why this can happen, and the most common is osteoarthritis. And so this is kind of wear and tear, age-related arthritis. There's also a genetic component to this as well. And so if you've had family members that have developed arthritis or had joint replacements, there's a higher likelihood that you may develop that condition as well. But there's other reasons to have arthritis as well. So post-traumatic, if there was ever any injury to the knee, if there was any fracture that went through the articular cartilage, that would predispose you to developing post-traumatic arthritis. Inflammatory arthritis, this is, falls into like rheumatoid arthritis, psoriatic arthritis, is where the cells of the body actually will attack the articular cartilage and destroy the cartilage from our own cells. Also, any sort of infection in the knee can lead to what we call post-infectious arthritis. And so arthritis starts an inflammatory response, which activates the pain receptors in our knee. This leads to swelling and an effusion of the joint because the synovial cells will then produce more synovial fluid. This can lead to decreased motion because the body's response is to try to stabilize the knee. So we form some what we call bone spurs or osteophytes that will kind of tense the ligaments and help stabilize the knee. It's as these pain receptors are more activated, they become like heightened, and so there's almost like kind of like a hyper pain response as the pain goes on and on. And so we judge arthritis based on the radiographic findings. And so the first thing that we see for arthritis is that we see that the joint space starts narrowing. Most of us have about 4 to 5 millimeters of joint space. And what we don't see on the x-ray is the cartilage. So we see the femur and we see the tibia, and in between those is the cartilage. And so as that space starts to decrease, that's representative of the cartilage wearing away. So that normal, 2 millimeters that we have on both sides slowly becomes less and less. The next thing that we're going to start to see is those osteophytes that form. So these are going to be on the outside parts of the bone, and they're going to start tensing the ligaments. The next thing that we're going to see is the bone is actually going to become more dense because it's seeing more force. It doesn't have that smooth articular surface that's gliding on it, and so we call that subchondral sclerosis, and that bone becomes more dark where the cartilage is. The last thing that we see is we start to see some cysts that form in the bone themselves. Patients always get concerned when we start talking about cysts. These are not cancerous cysts. It's just the bone's response to seeing the abnormal forces it will ultimately form a cyst. And so that pain that the body senses in arthritis is actually protective. And there's some patients that don't have that pain receptor response. And so we call this Charcot arthropathy, where patients lose that protective sensation, and they will come in with just very destroyed joints and completely worn out both sides of their joint. And so that pain helps keep us from having these catastrophic injuries, as difficult as it may be. Most patients wear out the inside part of the knee preferentially, but some patients wear out the outside as well. And so this kind of leads to two different deformities. So the most common form of arthritis, patients will become more bow-legged. The least common form, or less common, is more knock-kneed, and that's representative of knee cartilage wearing away preferentially on the outside part of the knee. Knee arthritis is very common. It's estimated that about 60 million Americans are living with arthritis now. That correlates to about 10 to 15% of patients over the age of 40 have knee arthritis. The American Academy of Orthopaedic Surgery has proposed some recommendations for how we treat knee arthritis. So we have strong scientific literature supporting a few treatment options. So topical anti-inflammatory medications like Voltaren gel has good evidence for efficacy of patients with knee arthritis. We strongly recommend supervised exercise or aquatic therapy or unsupervised exercise with some guidance from your orthopedic surgeon. Self-management programs can be helpful, oral anti-inflammatory medications or Tylenol. Of all the literature that we have, this has the strongest support for how to treat patients with arthritis without surgery. There's some strong recommendations against the use of narcotics. So as we know with the opioid epidemic, these are addictive. They're not good at treating long-term pain. And so we recommend against the use of long-term narcotics or wedge insoles in the shoe to try to help straighten out the legs. There's evidence against. Injections are something that we talk about a lot. The American Academy of Orthopaedic Surgery recommendations for cortisone injections is a moderate recommendation 4. There's limited evidence for a platelet-rich plasma protein injection, And there's moderate recommendation against the use of hyaluronic acid or what we call gel injections for the treatment of osteoarthritis. And so just briefly talking about steroid injections, there's 18 high-quality studies, 6 moderate-quality studies that show that this is a good option for short-term pain relief. So if you look, most of the pain relief lasts up to about 3 months in patients that have cortisone injections. And this is a figure from one of those studies that it takes a pain level from about a 6 to a pain level of about 3 or 4 and lasts for about 3 months. It varies patient to patient, and the duration and effect of it can vary as well. We generally think of as the arthritis progresses, these work less and less. So it's better kind of an earlier moderate arthritis. There's one downside of cortisone injections that was found in this study. So this was from the Journal of American Medicine. It found that patients that had cortisone injections frequently for 2 years versus those that had placebo saline injections, they did MRIs before and after that 2-year period and found that if you had the cortisone injection group, you had more cartilage loss over that 2-year period than if you had the placebo injection. And so this has been looked at, and not always with the same results, but the thinking may be that the injection itself leads to it, or is the pain relief you're doing more with the knee. So we always caution against having frequent injections for a prolonged period of time. And so that's why sometimes surgeons will say you have, X number of injections that they're willing to give before, considering other treatments. Just a quick mention about platelet-rich plasma protein injections. So we have an ongoing search for effective non-operative osteoarthritis treatments. And so this kind of falls into the realm of regenerative biological therapies. And while PRP injections have not reversed arthritis, they have promoted healing and potentially decreased inflammation in patients with arthritis, and it may be beneficial. There's multiple studies that show good pain relief, and this may work longer than the cortisone injections. Some of these studies say that it works for 6 months versus 3 months for the cortisone injections. And there's also like stem cell injections that are, you're hearing more and more about. This is something it's very unregulated by the orthopedic community, and so I'm very hesitant about, having patients go and seek that treatment. We don't offer any at UCI, but you don't know exactly what's being injected or the efficacy of those stem cells that are being injected. So I always caution my patients against those. If our conservative treatments don't work, then we start talking about surgical options. And the surgical option that we talk about is joint replacement surgery. So you never have to have a joint replacement surgery. You consider surgery when you've exhausted all the non-operative treatment options and the pain's limiting you from what you want to do and things that are important in your life. You always have to weigh the risks and benefits of surgery. So we have a few hard stops to surgery. No smoking. Weight has to be controlled. You can't have any active infections. This is especially important for like dental infections. No, can't have uncontrolled diabetes, because what we're trying to do is prevent the risk of infection. If these joint replacement surgeries get infected, it can be a devastating complication. So a lot of what we do in the preoperative period is try to decrease that risk of infection as much as possible. And one thing I really try to focus on with my patients is the timing and social situation is just as important as the surgery itself. So you need to optimize that. You need to have your team around you that's going to help you recover from this surgery, because it's a prolonged recovery with a lot of physical therapy. And while your body's healing and you're in pain, we're expecting you to get motion of the knee. So you really have to have enablers around you in order to get the best possible outcome. Generally, when we think of knee replacements, we think of total knee replacements, but there's also an option for a unicompartmental knee arthroplasty. This is also known as a partial knee replacement. And this is one of my favorite operations, and it is a great option for some patients. So this is indicated when there's only one compartment. We talked about those 3 compartments, the medial, lateral, and patellofemoral. If only one compartment's affected and all the symptoms are localized to one compartment of the knee, partial knee replacement is something that we'll talk about, and it has some benefits. So those cruciate ligaments that we talked about earlier on, the ACL and the PCL, when you do a partial knee replacement, those remain intact. in all total knee replacements, at least the ACL is sacrificed. And so the kinematics of the knee and how the knee move are inherently going to be a little bit different in a total knee replacement, but maybe more similar in a partial knee replacement compared to our native knee. It's a less invasive approach. There's shorter rehab time, potentially greater range of motion, shorter hospital stay, less blood loss, lower risk of infection, and great 10-year follow-up in the right indications. There was a study looking at patients who had a partial knee replacement on one side and a total knee replacement on the other, and they said that their partial knee replacement felt more like a normal knee than the total knee replacement. There's some arguments against partial knee replacement, so it may not be as predictable because you can develop arthritis on the other compartments of the knee with time. Some registry data shows higher revision rate. There's higher rate of aseptic loosening, or the components potentially coming loose because there's not as big of a surface area for that component to be cemented or for the bone to grow into. And the conversion from a partial knee replacement to a full knee replacement is not as good as if you just did the full knee replacement right off the bat. And so it's really important that this is not a temporizing procedure, that you want to do the right surgery the first time, so you're not looking at revision knee replacements. There's some contraindications for partial knee replacements. So if you have inflammatory arthritis, if you have a flexion contracture where your knee won't go all the way out straight, if you have limited range of motion, or a significant deformity of the knee, those are sometimes difficult to correct with the partial knee replacement. And then if your ACL is torn, if you have patellofemoral arthritis, or sometimes higher weight. And so for those patients that aren't partial knee replacement candidates, we talk about total knee replacements where all of the compartments of the knee are resurfaced. In an orthopedic clinic, when a patient's getting a total knee replacement, we get these x-rays, and it's basically looking at the whole lower extremity. And so from the hip down to the ankle, we judge where that weight is going to be transmitted. And so in arthritis, the knee typically doesn't fall in that line, which is going to increase the force going through the arthritic knee. And so with a knee replacement, we're trying to look for a knee that's more in the center of that weight-bearing surface of the lower extremity. Traditionally, how we've done knee replacements is that we look at these x-rays, and then we are going to use these x-rays to complete the surgery intraoperatively. And so we put rods that go into the femoral canal, and we start making the resections of the bone based off those rods that are in the femoral canal. And then we make the resections, and we balance the soft tissue around those resections. And really, a knee replacement is more of a soft tissue operation than it is a bony operation. It's making sure that those ligaments, again, are working in concert and they're working together. Luckily, we have some new tools to try to balance the soft tissue. And so one of the things that I'm really excited about and that UCI has to offer is that we use computer and robotic assisted tools that give us as surgeons a lot more information about how your knee is before we start making some of those resections, and help give you the best, or give our patients the best knee replacements. So there's some drawbacks of the traditional knee replacement. So like I said, the rod has to go into the femoral canal, so we have to violate the femoral canal. It can be more difficult if there's complex femoral anatomy. If there's any hardware that had previously been placed, you can't put a rod that goes up there. And it doesn't really quantify the soft tissue tension. So like I said, we're really making cuts and kind of, then work with the soft tissue around the cuts. And sometimes there's some inherent inaccuracies and higher rates of outliers when traditional instrumentation is used. And so robotic knee replacement is how I do a majority of my knee replacements now. We say robotic surgery, but the surgeon is still completely under control. It's just a tool that helps accurately plan and accurately resect the bone and position the implants. And so there's multiple companies that have different robots to help with this procedure. And so essentially there is a computer with sensors and a computer program that senses or it gives information to a robotic arm that helps the surgeon plan for the surgery. And so one of the first things that we do is we map the anatomy of each patient's knee and register that in with the computer. We take it through a range of motion, and it gives us before we've made any sort of cuts or resections, it will give us the soft tissue tensioning. So in 0.5 millimeter increments, it will tell us, in flexion, on the inside part of the knee, it's this, on the outside part of the knee, it's this. And then as a surgeon, I'm able to take that information and I'm able to plan with the robotic system and on this screen intraoperatively how I position those components and what it's going to do to those potential spaces. So we're getting a lot more information earlier on in the operation, and as you can imagine, we're doing less soft tissue releases because of this. We're using the implants more to kind of help balance the knee than having to make those cuts and then balancing the soft tissue around it. And then once we have a plan, these tools are very accurate in helping us execute that plan. So instead of relying on a rod that goes into the femur, we're able to use this, and it's more accurate and has less outliers. And then so we take a patient that has lower extremities like this and make them nice and straight. And it's a much more personalized and customized procedure. It's a completely individualized operative plan based on the soft tissue tensioning and the patient's unique anatomy. We also get real-time feedback, and I'm able to make changes intraoperatively that are more difficult to make with our traditional instrumentation. So I'm constantly looking, assessing, and making adjustments during surgery based on the information that I'm getting back from the robotic system. I also think it provides enhanced surgical precision. It gives us, a high level of accuracy, and we're able to hit the targets that we're looking for. I think it improves the alignment and positioning of the components. When I plan a component positioning with the robot, I'm really confident that that's what we're going to end up with. I think it reduces the risk of malalignment and potentially earlier implant failures, and it's more soft tissue friendly, may lead to less pain and quicker recovery and quicker time out of the hospital for our patients. Also, one of the things at UCI is that we have residents. We're a teaching institution, so I take this job very seriously because I'm training the next generation of surgeons, and I want them to be able to take care of me in the future as well. And so I think that our learners now are very visual, and so to have that planning screen where we talk about how we rotation, the components and how that's going to affect the soft tissue balancing really helps them understand what we're doing with this procedure. When I was going through my education, it was just this huge graph and table that you just had to rote memorize. And I really wish I had that because it helps me understand, and it helps them understand, and they're able to, make adjustments and see how that would affect the knee replacement as well. There's good evidence in the literature that it decreases the length of stay if you have a robotic knee replacement, and patients take less opioids that have a robotic knee replacement compared to manual instrumentation. And I think this comes down to the soft tissue also not having the rod in the femoral canal. How we're going to utilize this in the future is that we're going to take all the data that we're getting from the robotic systems, and we're going to evaluate the long-term outcomes of patients that have knee replacements. And I think probably what it may show long-term is that these implants are potentially going to last longer because the soft tissue balancing is potentially better with them. At UCI, we also focus on a rapid recovery program. And so a lot of this, there's a very holistic approach when you have a joint replacement at UCI is that we want patients to be educated. So we have a joint replacement class that's on Zoom that patients go through. We are implementing a preoperative hydration program where, kind of analogous to if you were going to go run a marathon, you wouldn't want to do that if you were completely dehydrated. And so we're giving kind of like carbohydrate-rich drinks, like they're similar to Gatorade that you take the night before and the morning of surgery to try to make sure that you're as hydrated as possible. We work with our anesthesiologist to do a preoperative block, and we try to control pain many different ways. Like we talked about, opioids are not good long-term solutions, so there's other medications that we use that affect pain pathways differently than the opioid pathways. And then, and my job as a surgeon is try to, do the surgery with a soft tissue friendly and sparing as possible. And then we try to get patients up early with physical therapy and moving right away. We do physical therapy starting right after surgery, usually starting with home physical therapy and then transitioning to outpatient physical therapy after this. And ultimately, you know, my satisfaction is seeing my patients get back to the things that they love, whatever that may be. That makes me the happiest. And so that is my presentation on knee arthritis, and happy to open it up to any questions that you guys may have. I'll start here in the front.
Here I have a microphone.
Oh, we got a microphone, perfect.
So I'll be taking the microphone out to you so you can ask Dr. DiGiovanni your questions.
Is the robotic surgery longer or shorter and in terms of anesthesia and procedure than a conventional knee replacement?
That's a great question. And so most surgeons, once they've done, I think the studies have looked at about 20 robotic replacements, that it's time neutral. So it's the same whether they were going to do it with the robot or without.
It sounded like you were doing a lot of prep while somebody's lying there, kind of under anesthesia.
Yeah, of course.
Sorry. If you've had one knee replacement, is it conventional now to only do one at a time instead of two? And how do you adjust? Because if you're used to one regular knee and one arthritic knee, how do you even that up?
Yeah, so I generally recommend that patients do one at a time. There's no rules against it, but the recovery is more difficult. The thing I worry about as a surgeon is it's longer time under anesthesia, and there's a higher risk of needing a blood transfusion if you have both knees replaced at the same time. And so we know that those blood transfusions can increase the rate of infection, and so you know that's kind of where my brain goes. So I usually say try to focus on rehabbing one first, and then you know, once you recover, you can do the other one. And you know, if you have both knees that are arthritic during the recovery process, the other knee may be more painful, and so we could, you know, potentially talk about doing a cortisone injection or things like that to try to help with the pain from that.
Because 6 years into it, it's very different. My ambulatory, everything, if you're active and you still do sports and things like that, it's very lopsided to have one knee that's replaced.
So you wish you would have done both? Yeah. So I would say that generally it's about 3 months between is what I would recommend.
Doctor, could you comment on something called Baker's cyst and how knee arthritis impacts that?
Yes, great question. So Baker's cyst is a connection with the joint in the posterior aspect of the knee. And so we think that generally a meniscus tear, which the meniscus does tear with arthritis as that space decreases, allows an opening into the posterior aspect of the knee. And so as the knee swells, that area in the back of the knee fills up with fluid, and we call that area Baker's cyst. And it can be painful in the back of the knee, especially with, you know, flexion. They can be challenging to deal with because you can't get that space closed down. You just try to decrease the inflammation. And so we can talk about aspirating it and injecting it with cortisone to try to prevent it from filling back up with fluid. But generally those will recur.
If it bursts, liquid goes down the calf.
Yeah. Mm-hmm.
Body just over time absorbs it.
Yeah. And patients actually sometimes find that bursting is actually kind of therapeutic. But yeah, the body will resorb the fluid.
Okay, so I noticed on your notes, and you also stated that you do not recommend the hydrochloric injection, the gel injects with OA. Why?
So the American Academy of Orthopaedic Surgeries, they've reviewed all the studies and have not found it to be efficacious, looking at all the studies. With that being said, I still talk to my patients about it, and I think it can be a temporizing solution for pain, especially in patients who haven't responded well to cortisone injections. So I still do offer it to my patients, but I just try to educate them about the literature as much as possible, that, you know, it may not be as efficacious. But if the alternative is knee replacement and we're trying to postpone or avoid that, then I think that there's very little harm in trying a hyaluronic acid injection.
So how long is that effective, though? It's longer than a cortisone shot, is that correct?
The studies that show that it's effective, again, it's kind of more like the PRP where it's about 6 months that it works for. Yeah, but these studies they're not as, you know, advantageous as the cortisone injections, and so that's why we have a harder time getting the insurance companies to approve them, because they focus on those studies as well. So.
That was a question I was going to ask you, because I had the gel injections, those painful things, about 5-6 years ago, and I tried the cortisone. It didn't last, of course, and I have not had to redo it, and I ski and I bike and I hike, and no problem. I don't know if I would need it again, but would I be able to have it again if it squirts all out or whatever happens to it?
Yeah, of course. And so I think that, you know, I have patients very similar that respond excellent to hyaluronic acid injections. And so not everybody's knee reads the studies, you know, and so it's always something that we talk about.
Lucky me.
And we just document that. Insurance companies, we can, you know, sometimes they make us jump through some hoops, but we can generally get them. And it brings up a good point too of, you know, a lot of these things are temporary, but if you can strengthen the muscles and the ligaments and the tendons and everything around the knee during that time while it's feeling good, sometimes that can lead to more benefit in the future as well. And so that's really what I try to focus on, is try to get the knee feeling well, try to strengthen it during that time, try to optimize things as much as possible. And then, those are the stories that I like hearing.
I have a question about
Yeah.
bone spurs.
Mm-hmm.
What causes them, and do they ever go away, or are they the thing that gives one, like me, the pain, or also the lack of fluid in my knee? And also the last question is stem cell research.
Yeah.
Where is it now?
Yeah, all good questions. So bone spurs, so as the knee becomes more arthritic, the end stage of, like, if you look back over, like, what the body tries to do with arthritis and with pain and with painful joints is it tries to restrict the motion. So if you let this process go out long term, patients can actually fuse their joints. So patients can have their body will internally fuse, or sometimes we see this in the back where it'll fuse areas of motion to try to decrease the pain. And so it's the joint's reaction to the pain and the abnormal forces is that it's going to create bone spurs to try to stabilize and decrease the motion and tighten those ligaments around the knee. And so that's what causes the bone spurs. The bone spurs may be painful because they're pushing on the soft tissues, but I generally think of arthritic pain as more of a, inflammatory response of the pain receptors than of the bone spurs themselves. It's kind of this inflammatory process, and that's why the anti-inflammatory medications are kind of, one of the things that really have shown to be helpful.
Do they go away or no?
Bone spurs do not go away. No, they go away with surgery because we take them away. But yes, the body will not take them away.
So when they merge or whatever, will that limit your range of motion? Is that what's limiting it?
Mm-hmm. Yeah, because it tightens the capsule, it tightens the ligaments, and decreases the motion through that. And sometimes the bone spurs get bad enough that they actually will bump into each other and limit motion that way if it goes on long enough.
So stem cells, the other question.
Stem cell, yeah. So it's a challenging thing to study because a lot of times the embryonic stem cells, where are we getting these stem cells from? And there's a lot of ethical concerns about that as well. And so the studies we haven't shown in any of the studies to have the holy grail is going to be regenerating cartilage. There's no vascular supply, so when are we going to be able to inject something that's going to take an area of, cartilage loss and grow cartilage back? And we're not there yet. None of these injections have shown to do that. But again, it's challenging to study at like an institutional level because of the ethical concerns of some of them injections.
One last thing, are there other countries that are doing that? Or no?
Yeah, I think it's easier in other countries, but yeah, we haven't found the injection yet or the way to regrow cartilage yet.
Hi, I don't remember hearing much about arthroscopy. Is there a reason that you didn't mention it?
So arthroscopy for arthritis is generally not advised. So one of the things that commonly happens is, so we get an MRI that there's arthritis and a tear of the meniscus. And at that point, it's really important to differentiate what's causing the pain. So the only reason to do an arthroscopic surgery in the setting of both arthritis and a meniscal tear is if we think that the meniscus is catching and causing what we call mechanical symptoms. So mechanical symptoms would be a block to flexion or extension, or like you can feel it getting caught in the joint. An arthroscopic surgery kind of for diffuse pain and activity-related pain in that setting, sometimes it will just aggravate the arthritis more. And so it's sometimes hard, but a lot of times I'm counseling the patients that there is a meniscus tear, but that's secondary to the arthritis. The arthritis is the main cause, and so if you don't address the arthritis, then it's, the surgery is not going to be successful.
Is that individual, or that's kind of a truism that the arthritis is the more painful thing, not the meniscus tear?
I guess it could be individual, but really what we're looking for is those mechanical symptoms, and so that's really what we're trying to tease out. There are patients that do physical therapy, are not ready for knee replacement, may benefit from an arthroscopic surgery, but if you look at the population-based studies, we're not sure how efficacious that is. But again, something you can talk about individual. Yeah.
Thank you.
Yes.
I have a quick question. Are osteophytes the same as calcifications?
So they can be different. So can be calcifications that form in muscles and tendons. Osteophytes are typically attached to the bones themselves, and so there can be difference between the two.
So if there are calcifications, is that something that requires surgery, or can they do another procedure? Because I have had several shots already, and it's still very painful.
Yeah.
To move.
So sometimes if calcifications can be like loose bodies that we think are getting caught in the knee joint, and that can be painful. And so sometimes by removing those, that could be a reason to consider surgery.
Thank you. And just one more thing. Do you recommend meloxicam for inflammation, or do you have any other recommendations to make?
Yeah, meloxicam is a good anti-inflammatory medication.
Okay.
And Tylenol, they work a little bit differently, and so you can kind of alternate. But I wouldn't take meloxicam or ibuprofen together, or leave, just one of those in that classification, and then Tylenol.
Thank you.
Mm-hmm.
Recently, the Washington Post had an article about a month ago about an Israeli company that's making something called Agocal, or Agilical. It's a calcium carbonate from coral, and it was released in 2013, and now it's 11 years later, and there's they had all these MRI studies that showed cartilage regeneration. And I know that you said that the ideal ejection, presumably that one as well, has not been discovered. But is that any good for temporizing?
So I don't recommend it for my patients. I know that there's a lot of the things that we see in medicine are kind of cyclical. And so a company will kind of grab on to potentially research that's been done in the past and kind of And so we've seen various types of these injections before, and they haven't been efficacious. And it seems like every once in a while there's another one that'll kind of come onto the market years later. And so I think the long-term studies of the earlier, and I don't know if there's much difference with this newer one than ones that had potentially been done. So it's not something that I recommend for my patients in practice.
At 67, I'm finding myself going down this road. I have a right knee that does have arthritis. I have to drag it up the stairs, right? So I'm going up the stairs with my left leg. When we talked about what my options were, the orthopedic doctor said that pretty much things last only about 10 years because the cement doesn't hold. So I'm not looking forward to going through this for at least another 10 years before I look into finally getting a new knee or something. How long, with what I saw, whether it's the partial or the whole on a knee, is that correct, that cements only hold for so long and pretty much about 10 years, and you really can only do one knee replacement?
Yeah, so great question. I'm glad you brought it up. So technology's improved, and there's a few things that have changed. So a knee replacement is made up of a metal femoral cap and a metal tibia cap, and then in between is a polyethylene liner. And in the early 2000s, that polyethylene liner, we started cross-linking it, which we hit it with some radiation, it cross-links, and the wear characteristics were much better with the newer generation of polyethylene. And so we've seen a pretty significant decrease in the rate of revisions that we're doing in joints that were done after that kind of 2000s period. And so if you look, we're about 8 out of 10 are still doing well at 20 years. And so we're hopeful that, we'll continue to see that trend longer and longer. But you're right, the other interface is the implant bone interface. And so cement is how most knee replacements are held to the bones. But we now also have some technology of components where the bone will actually grow into the component itself. So a majority of our hip replacements are done that way. We call it press fit or cementless, but it essentially is a biological interdigitation of the bone to the implant. And so, some patients are potentially candidates for having cementless knee replacements where the bone will grow in, and we think if we get that biological interface that may last longer than cement and may decrease the reason for some of these revisions in the future. Mm-hmm. But great question.
Hi. So my question is about the early signs of osteoarthritis and slowing the progression. I know you mentioned the NSAIDs, and I'm just wondering what else. Yeah,
so the hallmark symptoms of arthritis is pain, swelling, decreased motion, difficulty with activities. Usually osteoarthritis or wear and tear arthritis is worse after activities. So most patients have pain at night or pain that wakes them up at night after activities. Mm-hmm. And generally what I see is patients are like, I used to be able to walk 3 miles. Now I find that if I walk 1.5 miles, I'm okay. But if I do 2 miles, then it's more. So great question. Slowing the progression of arthritis is about decreasing the amount of force that the joint sees. And so when we're going up and down stairs, the stairs and the floor imparts force on our legs as well as our body to the floor. And it's about 8 times body weight is going through the knee when we're going up and down stairs or doing squats. And so really one of the important things is our body weight is an important factor for how much force is going through the knee. Also the shoes that we wear. And so I recommend patients wear good supportive shoes that have good padding and heel inserts. Hokas are kind of like the popular shoe right now, but they have really big heels with that have a lot of support. And so generally I recommend good shoe wear, decrease the amount of force by trying to decrease body weight to a healthy level, and then also strengthening the muscles around the knee joint can decrease the amount of force that the joint's seeing. There's other, supplements like glucosamine, chondroitin sulfate that are thought to be cartilage protective, and I do recommend those. There hasn't been a good study to show that, a subset of patients takes these and then, a patient doesn't, and then we see where they end up in 40 years. That's a really hard study to do, tracking it over that long. And so it doesn't have that study to say that we should, but I see very little downside to it. And so I think that glucosamine chondroitin sulfate may be beneficial, and you know, at least it shouldn't have any significant side effects.
That's good to know. Thank you so much.
Mhm.
All right, before I forget, sorry, I'll forget. My understanding is that there is an immune response. It's kind of a downward spiral that contributes even to osteoarthritis. I'm not talking rheumatoid arthritis. I might have misunderstood what I read, or I'm oversimplifying now, so bear with me. But if that's the case, then after a, let's say, whatever knee replacement extent is necessary, whether it's total or partial, does that quell the immune response, or is there anything else necessary? Yeah.
Yeah, good question. So yes, there's inflammatory mediators that are produced in arthritis that will, you know, alert some of the pain receptors in the knee and cause, you know, pain and swelling in the knee. And so if you're able to remove the source of that inflammation, which is the cartilage loss and the bone rubbing on the bone, you know, can decrease that. And hopefully, you know, our goal is to have a pain-free knee that's stable and that moves well. Yes.
Thank you very much. Based on the questions tonight, it appears as though women are experiencing severe knee pain more than men. Is that true? And if so, why?
Well, I think all the men are watching the baseball game. No, no, that's a very astute observation, though. So knee arthritis is more common in women than it is in men, and we don't completely know why. Women are also more predisposed to having ACL tears than men, and I think some of it may come down to kind of the shape of the hips and the knee alignment, and then also the laxity in the ligaments as well may play a role in that. But there is a higher rate of arthritis in women than men, so very good observation.
I had a question about the type of exercise that you do recommend or that you think you should avoid if you have, and the reason I ask is because I was recommended I get physical therapy, and I went to the physical therapist, and what she was doing was Pilates. Well, I already do Pilates multiple times a week, so I'm not sure how advantageous that was. But she warned me, she said, you know, there's certain positions and things that will make it worse. But I never really got into what would make it worse. So can you just speak to the type of exercise that you would recommend and what you would avoid?
Yeah, great question. So low impact activities is generally what I recommend. And so I tell patients to avoid running, jumping, or lifting heavy weights with low repetitions. So for cardiovascular exercise, I really like swimming, walking, stationary biking, or the elliptical trainer, because that's lower impact on the knees themselves. And then if you're gonna do weights, I always recommend lower weights and higher repetition, and avoiding what we call open chain exercises. And so the most common one of these is the leg extension machine, where the bar goes across your tibias and you extend it out like that. That puts a lot of force across the knee and especially across the patellofemoral or the kneecap joint. And so generally we recommend avoiding those knee extension machines or the hamstring curls because of the force that it produces. And so usually like lunges or like a leg press would be better to try to strengthen those muscles. I also really like wall sits. Like you lean your back up against the wall, you kind of squat down and hold it there. You'll really feel it in your quadriceps muscles. And I think, you know, one of the keys to having good healthy knees is to have strong quads. And so I'm sure some of my patients have seen me do wall sits in clinic demonstrating, but that's one of the things that I recommend. Squats are okay. This is all very generalized though. Ultimately I tell patients that if you have a good physical therapist that can help guide you, that's really important, because they get to spend a lot of time with you and they get to see you go through these motions and how your body reacts. The other thing is listen to your body. If your body's telling you like, ouch, that's painful, then you need to modify somehow, or that is just not a good exercise. And so the elliptical trainer may be great for most patients, but there may be a few patients where it, that bothers it more, or, affects the back more. And so I really empower patients to listen to their body. Some pain as the muscles regenerate is okay, but you have to know where that fine line is of like sharp pain. Your body's telling you like, hey, that's enough. And I really, really strongly recommend having a good physical therapist. And it's hard to know because there's a lot of physical therapy locations. There's a lot of physical therapists in those locations. And so trying to find one that works for you, that you feel like you're getting the most out of, is really important.
Are there more questions? Over here.
Yes, I have more trouble in a hip than I do my knees, and I get a clicking noise. What would that indicate, do you think?
Can be a few different things. Sometimes arthritis can cause like a clicking sensation. Sometimes there's a tendon that runs over the front of the knee that when you go into flexion and extension can kind of pop over the hip joint. And so it could be a snapping tendon as well. Typically, if it's hip arthritis, that's groin pain and pain that goes down the leg and sometimes into the knee. If it's in the side or the back, sometimes that's indication of other things as well.
Also, there was a mention about lateral wedge soles.
Mm-hmm.
And what is that?
So it's like an insole that affects the position of your foot to try to offload the force that goes through the knee. And we do not recommend those.
Okay, thank you.
Mm-hmm.
I have a follow-up on the glucosamine.
Yes.
It had been at least 20 years ago, my medical doctor, when I started having issues with my knee, said, try glucosamine, 30 days, you feel a difference, great, keep taking it. If you don't, then don't waste your money. I think I've been taking it all these 20 years because at the time that I stopped taking it, I noticed more pain. So it didn't eliminate my pain, but it seemed to help. Now, the physical therapist I'm seeing, I was asking him about it, and he said, well, your knee is a closed joint. There isn't a blood supply, so none of that is going in there. So what's your opinion?
Yeah. Like I said, the science isn't there to show that we would all be on it, right? And so I would say that there's some thinking that it can be protective to the cartilage, and it may have some, pain relief benefits. I think it has very few side effects or downsides, and so if my patients are interested in it, I encourage them to take it. Yeah, there is also financial.
I have a question about the robots.
Yeah.
Can you give us a visual of how it operates? Does it make incisions? What does it do?
Great question. So the surgeon's responsible for all of the incision and the soft tissue protection. It just has an arm that comes in. And so this one on the right here, I'll be holding on to that. There's a saw blade on the end of it, and it has a plane and a trajectory that it can only operate within. And so it basically is, based on that plan, it knows that this cut needs to be in this plane at this angle. And so it will only work if I'm pushing the button and moving it forward. And so it's not really a robot in the fact that it's, self-aware and is doing a lot of the surgery itself. And who knows, maybe in the future it will be, a surgeon supervising robots, but not there yet. Right now it's non-autonomous. The surgeon's in complete control. I think of it more as a tool than a robot.
That's what I was going to say. It's a tool.
Yeah.
Yes. But it's probably is more precise than the human.
Yeah. So like I said, there's some variations in some patients, like femur. So when we were putting the rod in the canal and then we pin a block, there's more room for error based on the steps that we had traditionally done in knee replacement. Granted, we get fantastic results with traditional knee replacement as well, but I think that this is going to help us be more reproducible, more accurate over a longer period of time.
We have a question in the back.
Yes, Doctor, I had, years ago, I've had meniscus surgery twice on both knees. And I was having a lot of pain in my left knee, and doctor prescribed an offload brace. And that's been, I don't wear it daily, but if I hike, I boat, I paddle, I always wear my offload brace to stabilize the knee. Is that,
Yeah.
you ever recommend that?
Yeah, I do. Bracing can be great, and there's a lot of variations in braces. There's, simple sleeves that provide some compression, to some that have hinges and straps and supports, and so an offloader brace kind of falls into that. And I think it can be helpful, especially if patients have arthritis that affects one of the compartments. So what an offloader brace does, it's got a metal support, and it has some straps that will kind of correct the knee deformity a little bit, and will offload the pressure, hence the offloader name, of the arthritic compartment. And so I always, I try to do everything short of surgery, and so offloader brace is always something I talk about with my patients. And it doesn't fall into the strong recommendation study, but that there is some studies that show that it's advantageous, and so it can be a good treatment option.
Did you say that the robotic devices help with the measurements and the balancing and give you the numbers that you need? Were you able to hear me?
Yes, yeah. Yes, it does. It helps us. We're able to make a lot of the assessment before we have to actually commit to making, resections of bone. So when we do a knee replacement, we remove the areas of bone that are arthritic, and we have to create a surface area that can support that metal implant. And so with the robot, we're able to assess that soft tissue. We're able to size the implants. There's a lot of factors related to the implant, and so the robot is able to help us kind of control all those factors and put it onto a screen that's easy to digest and take in.
Last question. More than a robot in that it's not doing things. It sounds more like a computer.
Yeah. There's a computer program, that's associated with it as well. That gives us a lot of information. Mm-hmm.
Last.
Yeah, so the average recovery for a knee replacement, I generally tell my patients to expect about 3 months of recovery. And recovery, there's different points that we're looking for. So generally you're getting up and walking the same day as surgery. So you're using a walker, and then you're gonna transition off a walker to a cane. But I'd say at about 3 months, you've done most of the recovery, but the full recovery takes about 1 year. So patients recover up to a year from a knee replacement. But if you have a job that requires a lot of like walking, driving, manual labor kind of stuff, I generally recommend, asking your boss or your employer for about 3 months off, and then you can always be the hero that comes back early, then ask for more time off.
All right, thank you, Dr. Giovanni.
Yeah.
Our next meeting will be November 28th, and it's going to be on headaches. Headaches. So we hope to see you then. Thank you for coming.